got you. We're good? All righty. We'll call to order this May 8th Medical Services Board meeting, and we'll start with the roll call, Judy.
Christy Blakely. Present. Patricia Gibbons.
Present.
Brigida Hughes.
Present.
Brenda Lacombe.
Here.
Paul Malinkovich.
Here.
Amanda Moore.
Here.
Jenny Riley. Here. Donna Roberts.
Present.
Mike Stahl.
Here.
Mary Young.
Here.
We have 10.
Great. Wonderful. Good morning, everybody. General announcements, date and location of the next Medical Services Board meeting. The next meeting is scheduled to be held Friday, June 12, 2015, beginning at 9 a.m. here at 303 East 17th Avenue, Denver, Colorado, in the 7th floor conference room. It is a policy of this board and the department to remind everyone in attendance that this facility is private property. The capacity of the meeting room is 80. Please do not block the doors or stand around the edges of the room. Please turn off cell phones while in the meeting room as they interfere with the recording equipment. And then I'd look for a motion for the approval of the minutes of April 10th.
So moved.
Second.
Got a motion and a second. Any discussion on the April 10th minutes? Seeing none, all those in favor signify by saying aye.
Aye.
Mary?
Aye.
Pat?
Aye.
Very good. We got approval of the minutes. First rule, we do have an emergency rule. So if I could have a motion for emergency adoption.
Move that all emergency rules that are adopted include a finding that their immediate adoption is imperatively necessary to comply with state or federal law or federal regulation or for the preservation of public health, safety, or welfare, and that compliance with CRS 24-4-103 would be contrary to the public interest. Move the emergency adoption.
Hold on a quick second then. Could I have a second on that motion? Got a second. All those in favor of the emergency adoption signify by saying aye.
Aye.
Dr. Young?
Aye.
Dr. Givens?
Aye.
All right, we've got approval of that. Now, if you want to move into the document one motion, please.
Move the emergency adoption of document 01 MSB-05-04-3-A, revision to the Medical Assistance Special Financing Division rule concerning the hospital provider fee collection and disbursement, section 8.2003 and 8.2004, incorporating the statement of basis and purpose and specific statutory authority contained in the record.
Second.
Okay, got a motion and a second on document one. Thank you. And here to present for the department is Matt Hayes. Welcome.
Thank you. Thank you, Mr. Chair, members of the board. My name is Matt Haynes. I am the Provider Fee Financing Unit Supervisor. I am presenting for your consideration for emergency adoption, Medical Services Board 1504-03-A. That does concern the provider fee collection and disbursement under section 8.2000. The Hospital Provider Fee and Oversight and Advisory Board, as we updated last month, on last month's update, the department and some hospitals found some data errors with the data we were using for the hospital provider fee model. Those were data calculations supplied by our contractor, Public Consulting Group. We realized correcting those errors would have resulted in significant impacts to some providers if revisions were not made to the 2014-15 hospital provider fee model in the state plan amendments submitted to CMS. At the recommendation of the Oversight and Advisory Board, the department made revisions to that model and presented those revisions to the Oversight and Advisory Board at its March 17, 2015 meeting. The OAB approved those revisions unanimously at that meeting. To be in accordance with the revised model, the department does need to make two slight revisions to the rules that were approved in January, and I am bringing those emergency rules for your consideration today. The sections we are making changes to, first there is a slight change under the fee calculations. That is at 8.2003.A. I'll direct your attention to line 10. As a result of some of the data revisions, the outpatient charges calculations did change. So instead of the percent of charges being 2.0119% as the calculation methodology, that is revised to be 1.9447%. The second revision we needed to make is at 8.2004.e, the uncompensated care hospital supplemental Medicaid payment. I'll direct your attention to lines 16 and 17. Previously, for hospitals with 25 or fewer beds, we had $30 million going towards those facilities. That has been revised to be $33,500,000, which then changes the remaining allotment for the other providers in that payment, where the payment was originally $85,480,176. And I apologize, let me direct your attention to lines 20 and 21 for this information. That has been revised to $81,980,176.
Okay. Could you kind of explain why this is coming as an emergency rule?
Yes, Mr. Chair. The department did bring these, the final model as emergency to the Medical Services Board in January 2015 to allow the department to collect sufficient fees from hospitals to fund the health coverage expansions and hospital payments to comply with state statute and the Medicaid state plan agreement with the Centers for Medicare and Medicaid Services to cover the department and to cover the department's administrative cost. The proposed rule revisions here are necessary to reflect the approved revisions to the calculations and to comply with the proposed state plan amendment in order to ensure continuing health care coverage for the Medicaid and CHP Plus expansions funded by hospital provider fees and access to discounted health care services for CICP clients. The timeline to implement the proposed model requires emergency rulemaking in order to ensure that the regulatory framework is in place to allow sufficient time to reconcile to the proposed model and to collect the necessary fees in order to ensure coverage for the expansion populations.
Thank you.
My pleasure.
Questions from the board for Mr. Hayes on this at all? Any questions on the phone?
No.
All righty. We don't have anybody signed up for public testimony on document 1. Is there anyone here that would like to sign up? All right, seeing none, we do have a motion and a second for emergency adoption of document 1. All those in favor, signify by saying aye.
Aye.
Dr. Young?
Aye.
Dr. Gibbons?
Aye.
Very good. We have approval of document 1. Thank you very much.
Thank you. Appreciate that.
Okay, now we pre-selected Brenda to read the consent agenda.
So bear with me. Okay. Move the final permanent adoption by consent of document 02 MSB 15-02-23-A. Revision to the medical assistance eligibility rules concerning section 214 of the Children's Health Insurance Program Reauthorization Act of 2009, CHIPRA in parentheses, sections 8.100.1 and 8.100.4, G.2, document 03, MSB 15-02-23-B, revision to the Child Health Plan Plus rule concerning section 214 of the Children's Health Insurance Program Reauthorization Act of 2009, CHIPRA in parentheses, section 110. Document 04, MSB 14-11-19-D, revision to the Medical Assistance Health Program's Office Benefits and Operations Division rule concerning women's health services, section 8.731, document 05, MSB 14-09-16-B, revision to the Medical Assistance Health Program's Benefits and Operations Division rule concerning family planning services, section 8.730.4 and 8.770 abortion services, document 06, MSB 15-01-26-A, revision to the medical assistant home and community-based services for elderly, blind, and disabled rule concerning respite care, section 8.492, and document 07, MSB 15-02-18-C, revision to the Medical Assistance Health Information Office Rule concerning enrollment procedures, Section 8.013.1, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Thank you. Nice job. Got a motion and a second on that. Any of these rules that the board feels they'd like to pull from the consent agenda? Seeing none, all those in favor of the consent agenda, please signify by saying aye.
Aye.
Dr. Young?
Aye.
Dr. Gibbons?
Aye.
Very good. We have approval of the consent agenda. We have 2 rules up for final permanent adoption. And so if I could have a motion for document 8, please.
I'll move the final permanent adoption of document 08, MSB 15-02-18B, revision to the Medical Assistance Health Information Office Rule concerning provider screening regulations, Section 8.125, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Okay, got a motion and a second on document 8, and we should have Nathan Colkin and Kyle Brown here to present. Maybe? We went too fast. They saw all the rules and they didn't see it was a consent agenda. We'll wait a second to see who's all there. Hey, that was a consent agenda.
You guys are so efficient. I didn't even have time to.
So we have a motion and a second on document 8, and you're Kyle Brown?
That's
correct?
right.
All right. If you'd, I know this was presented last month, came back with some changes, and kind of walk us through the general rule again, but then what has changed from last month would be great.
Sure, yeah. So, I'm Kyle Brown. Thank you very much for having me, and I apologize for being a little bit late. I'm glad Nathan is here as well. Nathan, go ahead and introduce yourself.
All right. Good morning, Mr. President and board members. My name is Nathan Culkin. I am the Deputy Division Director for the Provider Payment Division. I'm here to present the rule concerning the provider screening regulations. You do have 2 versions. One is a red line version, and then another one is a clean version. We have the red line version out there because there were some changes to the rule from the AG's office and program integrity. And we just want to go through and show all the changes, but there isn't anything substantive that really changes the rule. It's just to clarify and provide additional clarifications throughout the rule. The department does intend to implement the Affordable Care Act provider screening requirements as issued by CMS. The rule does apply to all providers that serve Medicaid and CHIP Plus clients, and it is designed to prevent fraud, waste, and abuse. Providers are required to revalidate every 5 years, and all providers must be revalidated by March 2016. And I do have Kyle Brown here from the governor's office, and we can't let him go until he actually has this implemented, because he has all the technical.
So if you want to keep seeing me every month, you might want to reject this rule. Or if you're sick of me. So anyway, so the Nathan gave a great broad kind of overview of the rule. We've worked really hard, I think, over the course of the last 6-9 months, both internally here at the department and with our stakeholders to make sure that everybody understands what the new federal requirements are, and to the extent to which the department can be flexible on some of the requirements. Then we've really tried to make this rule as least burdensome as possible. So again, this is about preventing fraud, waste, and abuse, and it sets up particular categories of provider types under which folks enroll. For the first time, folks are going to have to re-enroll periodically, as Nathan mentioned, and verify to the department that they want to continue to be a part of the Medicaid program. There's also a fee associated with this in federal law that we have to charge unless we can get a waiver, and it is the department's intention to seek a global waiver for all of our providers in Medicaid in Colorado, so that the $553 fee does not become a burden for enrollment. I'm happy to answer any other questions, but there are on some of our providers, there are some additional requirements for enrollment, including site visits and background checks. And I know the department is working hard to make sure that that the department and all of our sort of partners and contractors are up to date and are going to have the capacity to carry those capabilities out. So, happy to take any questions.
Questions from the board at all on this rule? Dr. Markovich?
Thank you. I don't have any real questions on the rule, but I'm interested to the degree to which what the department is doing to educate the provider community, because I think there is the potential for this discouraging people from signing up to be providers, and I'm sure the department recognizes that. And my assumption is that there is a lot of work going on, but I'm interested in what is happening to educate the provider community.
So when I was at the department, we made a concerted effort to reach out to as many different provider organizations as possible. Since I've left the department, as I frequent the HCPF website, I've also noticed that there's now a button on top of the website that talks about revalidating providers.
Yes, we are starting to reach out to the provider community. We have this month was the first time in our provider bulletin where we're starting to communicate that to all the providers. We're also working with our vendor who's actually implementing this. They're planning on going out to other provider organizations to help educate those providers as well. So this is the first month where we first published it, but we will start talking to them more and more often as we get closer and closer.
I guess I would just encourage proactive outreach and not passive. Nobody. I mean, I'm not sure how many people are going to go push the button
right
on the
right
website.
That's true. Yeah. So we did. So in the past, we did some proactive outreach, and we actually worked with the various associations, and I don't know how many presentations I did on this rule, but I think that you're right that I'm sure the department will be working proactively coming forward. So.
And Dr. Markovich, next month I can provide in my department update some of the sort of approach that we're taking. I think our goal was to get the rule through so that we had everything in place, and then I know there's a cross-office team using our provider relations unit and a lot of staff from the health information office that are putting together a master plan on how we're going to roll this out. So I can provide that as part of my update or have a department update on that.
Thanks.
Yeah.
That'd be great.
Sounds like you're ahead of me.
So you hear the presentation.
That'll be an important rollout for this rule.
Absolutely.
Other questions from the board? It doesn't sound like there's any real substantial changes in just some AG language changes from last month to this month.
Yes, AG and our provider program integrity.
Okay. All right. No questions from the board. Nobody has signed up for public testimony on document 8. Would anyone like to testify? And seeing none, we do have a motion and a second for final permanent adoption of document 8. All those in favor signify by saying aye.
Aye.
Dr. Young?
Aye.
Dr. Gibbons?
Aye.
Very good. We got final permanent adoption of document 8. Thank you very much. Now we don't get to see you anymore.
I know.
Nice job. Very nice job.
Thank you, guys.
Could I have a motion for document 9, please?
Move the final permanent adoption of document 09, MSB 14-10-15-B. Revision to the Medical Assistance Health Programs Benefits Management Rules concerning Family Planning, Section 8.730, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
I got a motion and a second on document 9. Thank you. And we should have, where am I here? Melanie Reese
That would be me.
and Frank Herbst.
Good morning.
Good morning. Welcome.
So again, I'm Melanie Reese. Thank you for having me today. We brought this rule to you last month. We had some very late stakeholder input the day before our last meeting requesting one specific change on page 6 of your version that was dealing with covered services office visits. So that was the only modification that was requested. We worked with the stakeholder on the phone, and they agreed with the language that we put in. So originally we had one long sentence, and it wasn't as clear as it might have been. So we worked with them to modify the language on that to clarify follow-up services, the statement about follow-up services. That wasn't all in the initial office visit. This was the rule that we had presented and pulled out different definitions and different sections. The family planning rule originally had hysterectomy as part of the services and abortion. They were not appropriate within the family planning rule, so we had pulled those out and put those into 2 different rules, which you approved earlier this morning. So this is the only modification. The language in the family planning rule was basically the same as it was previously, although we did add a little language around the intent to document the service as it related to delaying, preventing, or planning for a pregnancy.
Great. Very subtle change from last month. Questions from the board at all on that change? Ms. Blakely?
Thank you. The medical necessity that is identified on page 6 of 10 in your document and on line 23. What is the definition? What is that definition? Which of the definitions for medical necessity is that referring to?
That would be the one that the standard one that we used, and I can get you that. You have that right offhand?
I'm sorry, what page is it?
So it's right here. How do we define medical necessity?
The definition for
So when medical necessity, excuse me, I can't speak this morning. When medical necessity is not specifically cited to, the default is to use the PI definition.
Okay. So
What's PI?
I apologize, program integrity.
So I have a follow-up question.
Please.
Follow-up question is, unless the mother would be under 21, and then it would be under the EPSDT?
That's correct.
Thank you.
Okay. Any other questions? Nobody has signed up for document 9. Would anyone like to sign up for document 9 to test of public testimony? Seeing none, we do have a motion and a second for approval, final permanent adoption of document 9. All those in favor signify by saying aye.
Aye.
Dr. Gibbons?
Aye.
Dr. Young?
Aye.
Very good. We have approval of document 9. Thank you both very much. I guess you both get to stay, though, don't you?
You too. Thank you.
Initial approval for document 10, if I could have a motion.
I move the initial approval of document 10, MSB 15-02-26-A, revision to the Medical Assistance Health Programs Benefits and Operations Rule concerning creation of maternity services, section 8.732, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Got a motion and a second on document 10. And again, we have Melanie Reese and Frank Herbst here to present. Welcome.
Thank you. So we're bringing you this new maternity service benefit, maternity service rule for your initial consideration. The department created this benefit coverage standard to identify and define maternity services in one place. The rule is set forth, again, the frequency, scope, and duration in rule in order to be consistent with other benefits for the department. This rule went through the normal public notice process, the rule review meeting to invite stakeholder input. We had no input during those time periods. However, the department did receive and incorporate input from several stakeholders through different venues. That was summarized in the stakeholder comment summary and included input from Sequinon Laboratories and KB Pharmaceuticals. This rule is presented in the newly developed standardized rule formatting that you've seen over the past several months. It follows the same structure, presenting headings of major topics such as the definitions, the client eligibility, provider eligibility, specifics about covered and non-covered services, and includes whether there are any requirements for prior authorization for this rule. For this rule, there's no crosswalk, as you've seen over the past several months, because, again, being a brand-new rule that was created, we did not need to pull any other phrasing out of previous rule. If there's any questions I can provide for this rule, I'm happy to answer them for you.
Dr. Milankovich?
Thank you. In a number of cases in this rule, it talks about in accordance with generally accepted prenatal care practice guidelines. And what does that mean? Does that mean guidelines developed by the department? Is it guidelines promulgated by the Society for OBGYN? I mean, what do you use as guidelines?
So we're referring to guidelines set by the practitioners, usually by the ACOG. But because maternity services aren't always specified by or aren't always performed by one specific group of doctors, maybe pediatrician, it may be a family practitioner, we're referring to the individual medical practitioner guidelines for normal services. But as a general rule, they're always overseen by ACOG and the standards of care. But we didn't define that specifically.
But I guess when you say the individual practitioners, you mean the practitioner's society?
Correct.
Not the individual practitioner.
Correct.
Not me as an individual practitioner setting my own guidelines.
Yes, thank you for the correction.
Thanks.
Follow up on that. Would it make sense to have that definition in there?
We considered that, and we decided that occasionally there are changes in the guidelines as more information comes up, that we didn't want to specifically call every single guideline out because it might change as more information came forth. So we were just...
But yeah, I'm not saying specifically highlight every guideline, but highlight who what was the term used again? The
society.
The society.
The medical society.
Of kind of where you're defaulting those guidelines to.
I think we could do that, although, again, there would be a few different societies that we would have to reference. For example, pediatricians can work with teens for deliveries. Their guidelines may be slightly different than ACOG would be. So, I mean, if that's something that's recommended, we certainly could consider putting that in there.
What's the board think? For clarity of the rule. Dr. Milankovich?
The reason I raised the question is that it could be a point of controversy or disagreement between individual practitioners who say, I follow this guideline set by Chiropractic Society, let's say. Or I follow this guideline set by naturopaths. And it may be worth saying professional societies promulgating guidelines relative to. I don't know how to get around it, but I'm just thinking that it may not be an issue. I mean, maybe it's not an issue that the department deals with, and maybe it's not an important one. But I think it'd be. I'm just thinking it's somewhat better to have some specificity about what guidelines you use.
Mm-hmm.
Good point.
Good point.
Mr. President, I have a question.
Yes, please go ahead.
I was interested in the last section related to services not covered. And I guess my question is in relation to the high-risk pregnancies and obviously then subsequent care for the child and the family situation. In the stakeholder groups and in your discussions, did you have any, or have you thought of having any consideration of supporting parenting and other educational classes and home support in terms of managing this high-risk child? Or, I think there's a potential for risk for families that have high-risk pregnancies and, long-term safety of the child, neglect, abuse, all those things. And I was just wondering if you all have talked about that, or are there other rules that cover parenting classes and support for families?
We did not get any stakeholder feedback specifically related to that. I wasn't aware of any specific input from other states dealing with parenting classes. Part of that may be covered under EPSDT coverage. And for the maternity rule specifically, it generally covers the services up only through the third month, 60 days from the date of the mother's delivery, and then the child is covered for a couple years after that. But as far as parenting classes, that was not one that we considered initially as being covered
and
services.
another piece of that is lactation and breastfeeding and those kinds of support services, again, for the high-risk baby and high-risk mom. So if it's not covered somewhere, I think it's something worth considering.
Thank you. I think, I believe the lactation, and I'm not sure of this, is covered under the pharmacy benefit. So, but it's not called out specifically in this rule. I believe they can, that breast milk pumps are part of the services, but again, it's not specifically called out in this rule.
So would it be possible to have someone to check on those things? I think that there could be a gap, obviously, for those families, and I would be concerned about not having some resources for both lactation, breastfeeding, and parenting.
I will certainly investigate that and get back with you on an answer for that. Thank you for the question.
Thank you.
Thank you.
Ms. Blakely?
Thank you. I agree. That was Patricia, wasn't it?
Mm-hmm.
Correct.
I wholeheartedly agree, and sad we didn't get stakeholder input. Breast pumps are under the ACA required, but know that parenting isn't under EPSDT, and the lactation absolutely should be something we should be considering as well, especially with this population. So I would agree.
Great. Thank you. Other questions from the board? We don't have anyone signed up for public testimony for document 10. Is there anyone here that would like to? And seeing none, we do have a motion and a second for initial approval of document 10. All those in favor signify by saying aye.
Aye.
Dr. Gibbons?
Aye.
Dr. Young?
Aye.
Great. We have initial approval of document 10. Thank you, and we'll see you back with some of those other questions and answered.
Absolutely.
That'd be great. Appreciate that. We only have one document that's even up for the consent agenda. Do people feel comfortable putting it on the consent, or do we want to hear feedback from the questions that were asked?
Hear feedback.
Okay. All righty. So we will not have a consent agenda next month, but then could I have a closing motion?
Move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference.
Second.
Got a motion and a second on the closing motion. All those in favor, signify by saying aye.
Aye.
Dr. Gibbons?
Aye.
Dr. Young?
Aye.
Very good. Thank you. That closes out the rules part of the agenda. We open forum. We do not have anyone signed up for open forum. Would anyone like to sign up? And seeing none, we'll move right on into department updates.
Sorry, can I ask something?
Yes.
We have a vacancy. Is there action that will be taken on that vacancy?
I'm hoping Gretchen will update us on that in her department update. Will you?
Yay!
No, I won't be. Will I? It's not. I don't think it's in my update. No. I think it's moving its way through the appointment process, and that's the only update that we have. That there's a slate that goes through the process with the governor's office, and then that process moves forward.
The advocacy in me is lonely. I need a buddy.
We can certainly try and commit to making sure we have some sort of update on where we are in that process.
That'd be great. That'd be great. Thank you.
Sure.
Okay, department and legislative update is first up, Josh Block and Zach Linkowitz. Welcome.
You didn't sleep in this morning, huh?
I slept in yesterday. Yes. Oh, do you want me to go first?
Yeah.
Sure. Sorry.
Morning, everybody. We're still
Not
waking
hearing
up.
well. Haven't had coffee yet. Good morning. My name is Zach Linkwitz. I'm the department's legislative
Hold on
liaison.
1 second, Zach. Excuse me.
Mr. Linkowitz.
Linkowitz.
Zach's update is written, and Josh's is on the iPad.
Josh is more organized than I am, so.
Very good.
Yeah, so hopefully Dana passed these out. This shows some of the bills that passed that impact HICPUF. Not all of them have been signed by the governor, so I can't commit to their ultimate approval, but I'm not aware of any concerns with them. Overall, I think that this was a very successful session. Given the political climate, it was a lot different than the last 2 years. I think the vast majority of our work involved the budget requests. I probably spent 95% of my time over at the Joint Budget Committee. Those 6 members drive an inordinate amount of work for our department, but we have, I think, the largest budget by total funds out of any department, so that sort of makes sense. We do have a relatively small legislative agenda. One of them, which we've talked about before, was our teen pregnancy and dropout prevention program. We had tried to work with the sponsor to see if we could get a late bill. Unfortunately, that didn't happen. Unfortunately, family planning services were not particularly popular this session. CDPHE's LARC bill, which wasn't really related, but both family planning services, ours had nothing to do with contraception, that also failed in the Senate. There is a sunset on our teen pregnancy and dropout prevention program, so it will go back to the legislature no matter what next year. I think we're working with Hilltop to figure out next steps, and no matter what, it will be another topic next session, so hopefully we'll have better luck with committee assignments. Our other bill, which was also a budget request, was our expansion of the children with autism waiver. That was passed. I think it was passed 85 to 15. If you look at 100 General Assembly members. So broad bipartisan support, Joint Budget Committee bill. I'm really proud of that bill, and I think it was a huge success for the department. It's going to be signed by the governor next Thursday, along with 2 other intellectual and developmental disability bills. One is consolidating the adult IDD waivers. We have to submit a waiver application to CMS by next July. That obviously doesn't mean that CMS will approve it by next July, but I'm sure you guys will be heavily involved in making those benefits. And then the crisis response pilot program that was also a Joint Budget Committee bill will also be signed next Thursday. And that's sort of figuring out how we intervene with persons with intellectual and developmental disabilities who have a co-occurring behavioral health issue. If they are in crisis, how do we sort of triage them and get them stabilized so that they don't end up in our prisons or in our emergency rooms. So looking forward to next Thursday and driving up to Evans to represent Young's territory, but I'm happy to answer any questions on any of the bills listed in here, or if you have bills that aren't in the packet. They're likely, one, don't impact HICPUF or didn't survive. There was a lot of bills that unfortunately did not survive, or fortunately, depending on your perspective, less to implement. Yeah, so I'm open for questions. Do you have any?
Board have any questions on the legislative area?
Not a question, just thank you for the autism. This is going to serve many of the children that have been missing services and families that have been in dire needs for support. So we really appreciate that. And I can hear Julie Ferrara's head shaking over there. So, from the Developmental Disability Council, so I believe that she's in agreement with me. Thank you.
Absolutely. And just one comment on that. I do want to mention that this is sort of the first step. We obviously, with all of our waivers, we have to get CMS approval. So we will be working with them over the next however many months to ensure approval and answer their questions. But we'll keep updated on that.
Ms. Riley?
I think there was a bill to move some technical moves on where the provider fee went. And that didn't make it, Greg?
Mr. President, Ms. Riley, that is correct. House Bill 1389 was a bill to change the way that the hospital provider fee is accounted for under Tabor. It would have created what's known as an enterprise, and that bill, essentially what it would have done is taken the $700 million of revenue that's collected under the hospital provider fee and said it's Tabor exempt. A little bit more complicated than that, obviously. That did not pass. It got through the House, but died in the Senate. I have heard Director Sobinet from the Governor's Office of State Planning and Budgeting talk about how it may become part of the budget package next year. There's a lot of uncertainty at the moment about what's going to happen for fiscal year 16-17. Waiting to hear direction from OSPB, and I'm sure that come November we'll be here talking about the solutions and potential problems that we are about to face.
Other questions from the board? Just have a comment then for Zach as we move forward next year with the pregnancy prevention dropout bill. Let us know as soon as we can to start working on that and how the providers can help you in that area.
Absolutely. I appreciate that.
Yep. Great. Thanks. All right. Josh, you want to give us a budget update?
Thank you, Mr. President. Again, my name is Josh Block. I am the Budget Director for Healthcare Policy and Financing. The handout, which I believe is on your iPad and also online, walks through in a brief table all of the budget initiatives that we had. I have previously come before this board to talk about what they are, but I'll go through them again in brief, along with a little bit of dates. What you'll note here is that my list starts with our request R6, R1s through 5, our requests that primarily deal with the ongoing cost and caseload that we have. They don't generally contain new policy. We just drew up our projections, make sure that we have the right amount of funding for our base Medicaid programs, including our programs for CHIP and our programs for people with intellectual and developmental disabilities. Of note, R5 is the request that we submit a forecast for people with IDD. We are continuing to be successful in terms of maintaining the policy of having no wait list for individuals on the Children's Extensive Support Waiver and the Supported Living Services Waiver. We continue to add enrollments for folks with developmental disabilities when they're in need of emergency placements or foster care transitions or things like that. So with that, our priority number R6 was about changing the way that we determined income for most Medicaid clients, switching to a determination based on how much income they earned through the year. That was passed, although some items in that request were not, in particular an item for a study on continuous eligibility for adults, which would have required a demonstration waiver from CMS. And also we tried to get a 1-month grace period for the CHIP Plus enrollment fee. That also was not successful. Our request, R7, was about implementing a participant-directed program in our home and community-based services waiver for folks with for supported living services, again, folks who have an intellectual or developmental disability. Participant direction was added in a 2005 bill, but we have been unable to implement it in part due to fiscal constraints. We were given the funding this year, and so we'll be moving forward with that. We also received some resources to help support the Community First Choice Council, which will help reform our waivers and move personal care around and do a whole bunch of other wonderful things. As Zach mentioned, our request R8 was included in House Bill 151186 that is being sent to the Governor. That includes not just the elimination of the wait list, but it also allows people to get services up to age 8 and increases the cap on services. It was previously $25,000 per person per year. That's now going up in a manner that is essentially pegged to inflation, but the Joint Budget Committee and General Assembly will have the ability to set that cap as they see fit. R9 is about personal health records and online health education. We received approval for that. That will be implemented with our new Medicaid Management Information System, allowing clients better access to their health records. R10 was a request that allowed us to beef up our customer service capacity. We're adding 25 FTE to help deal with the phone calls that we receive, the emails, the online chats, and all those things. With the expansion of the Affordable Care Act and Senate Bill 13200, our customer service staff have been a bit overwhelmed, so we're happy to get them to support and make sure that clients can get help when they need it. R11 did not pass. That was an initiative to help better integrate some local public health agencies with our Accountable Care Collaborative. Although it didn't pass as we wrote it, the Joint Budget Committee took the amount of money that we requested and gave it directly to the local public health agencies. So even though it's not quite as we envisioned those folks who are working out in the counties will actually get some additional resources there. And so not exactly the outcome we wanted, but not a bad outcome nonetheless. Our request R12 is about provider rate increases, and there are provider rate increases this year, which is always nice to come here and talk about, as opposed to the years where I've had to come and talk about decreases. In general, there has been a 0.5% across-the-board rate increase, a 1.7% increase for the waiver program serving to people with developmental and intellectual disabilities. In addition to those rate increases, there have been a number of targeted rate increases as well. The department worked throughout the year to develop a plan, and over a large number of meetings with the Joint Budget Committee, we've identified a whole bunch of areas that will get additional targeted help. In the back of this document, starting on page 5, I believe, there's a list of all the targeted rate increases, including a link to a document on the Joint Budget Committee's website that describes what each of those are in detail. Request R13 was funding to help the department re-procure the Accountable Care Collaborative. That's coming up here, I believe July 1, 2017 is when that needs to be effective. So we'll be doing a RFP, and that will be all sorts of fun for everybody involved. The Accountable Care Collaborative is the foremost program the department is running around primary care and making sure that clients are connected with the resources that they need, so they're not wandering around our fee-for-service system on their own. R14 and R15 are about enhancing our financial oversight of the program. R14 is about the primary care fund. R15 is about managed care organizations. The idea there is not that we're going to go forth and start really putting the screws to providers, but we do have to ensure that the money we are allocating to these providers is being properly spent in accordance with statute and state rule. R16 is funding to participate in the Comprehensive Primary Care Initiative. And then R17 is R17 was funding related to Senate Bill 14-215, which was implementing some of the money that the state has received under the recreational marijuana funds. Because the revenue for those programs from marijuana taxes came in slightly below where the governor's office originally projected. Some of the programs that were funded in fiscal year 14-15 were not funded this year. There is a bill out there that would send an initiative to the voters to retain some of the money above the Tabor Reserve. There's a complicated issue there involving how much money the Legislative Council originally predicted in terms of revenue and how much they actually received. They're not allowed to keep all the revenue because they are actually limited by that projection. So some of the things that we didn't receive in terms of this bill, which included a grant program and then also funding for the behavioral health organizations to run a substance use disorder program, they weren't funded, but they could potentially come back in future years depending on the outcome of that referendum. R18 was a technical item related to helping improve one of our case management systems known as DDD Web, also referred to as CCMS, although I don't quite remember the acronym there. R19 was a technical adjustment on our public school health budget, where public schools receive federal funds to administer services to Medicaid clients. They don't have to contribute any additional money. We certify their expenditure, and we're able to draw down federal funds. On page 3, the only other item of note from our budget agenda was the department received 1 FTE to help us investigate, to help us implement a predictive analytics system to help us prevent fraud before it happens, potentially, giving us red flags to see whether or not a claim looks like it could be fraudulent before money goes out the door and we have to try to recover it. In addition to the items that the department sought through the budget process, the JBC added a few items of their own. They're listed on page 4. There are three of them. One of them was actually covered in a bill. The first item here was an increase to the home modification lifetime cap. This is the second time the Joint Budget Committee has put funding towards it. Individuals who are on certain home and community-based waivers can get a one-time grant or a maximum amount over the course of their lifetimes to make adjustments to their homes. Things can include something like a wheelchair ramp or modifications to a shower, things that enable them to help live in their homes longer as opposed to needing a nursing facility. The GBC is trying to get that cap up to $20,000. They did not appropriate enough funding to do it. We anticipate the new cap is going to be about $14,000 right now. The second item they approved was the dual diagnosis pilot program. Zach mentioned that earlier. I believe it became a bill. The idea there is that for folks with intellectual and developmental disabilities who also have coexisting behavioral health condition, to try to find a way to better serve those clients, better integrate them through the BHO program, and make sure that we generally find better outcomes. And then finally, the JBC provided some additional funding to help finance the department's, or to help provide resources for the Community Living Advisory Group, affectionately known as the CLAG, although some people don't really like that acronym. There is funding in there to help do some policy analysis, to help the group find of their recommendations, help develop an order on which to implement them, and help flesh out some of the things that they'd like to do. And then some additional funding to do some fiscal analysis, because as we enter into a brave new world of labor consolidation and modernization, things may need to change, and it may involve clients getting more or less services, and so we need to understand what that's going to be about. The targeted rate increases I spoke of earlier are beginning on page 5. Again, there is a link in this document to the JBC's website that has a department document which outlines all of the things that we've done. We didn't receive approval for everything we did, but a lot of areas where funding has been inadequate and wouldn't really suffice with a 1.5% rate increase received some targeted funding. So we're looking forward to implementing those. That is the end of my update. That's pretty much what's been included in this year's long bill. We will be bringing all sorts of fun rules back to this committee to approve the actual policies that they've done. Our requests, as they've been written, are available on our website. You can read high-level synopses on the JBC's website under their long bill narrative, and also the figure-setting document. And if you need any of those, I'd be happy to provide them through Ms. Carey and send them out to the board or anybody else who's interested in that. So with that, I'd be happy to take any questions or run screaming from the building. Hide somewhere under my desk.
Very, very nice review of the long bill. It's not easy to capture like that, so I appreciate that. Any questions from the board? Dr. Malinkovich?
Thank you. Just one question. I'm a little bit more. I'm interested in the Comprehensive Primary Care Initiative funding. Is that funding for practitioners who participate in the CPCI? How does that work?
So, Dr. Malinkovich, I'm not an expert in exactly what CPCI is. My understanding here is that CPCI is essentially a conglomerate or a confab of a number of different provider organizations, or a number of different providers, including the department. And what we're trying to do is essentially pay our fair share. I don't quite know how the money gets distributed. It's been a while since I've actually read the request and written the request, but I don't think it is direct payments to providers. I think it's money going to the organization to fund some of their activities.
Actually, it's CPCI is part of a federal initiative to try and get multi-payer investment in transforming primary care, and so Medicaid's a participant in the statewide structure for that, and we do pay providers. It's all federal money, so it's no state dollars, but we pass through federal dollars, again, as an equal participant in this conglomeration of payers.
It's a multi-payer, yeah.
It is multi-payer, and it's important because, and we can provide an update on it, it is going to be and we've talked a little bit about, and Judy and I decided there were too many department updates on this agenda, so next month, hopefully having Vatsala from SIM, Vatsala Pati, the director of the SIM project. So many of those current payers are also going to be part of then the SIM work, and so it's been a nice platform for us to do that.
So more information. I'd just be interested.
Sure.
Thanks, great.
Thanks. Any other questions from the board? All right. Thank you both very much for your reviews and all your work this year. Appreciate
See you guys next year. Next fiscal year.
There you go. The next department update we have is the Customer Contract Center overview, and Christine Comer is going to be coming. Okay. We'll jump ahead one then to Project Echo, and we have Elizabeth Baskett here to present. Make you jump up the agenda.
Sure.
Get you out of here quicker, right?
We're prepared.
And I believe this handout is also on our iPads.
Yes, there's there's one handout. They're connected. Good morning, Mr. Chairman and members of the board. I'm Elizabeth Baskett with the Program Innovation section here at the department. I haven't been here in a while. I was here a lot when we were doing expansion, and since then we've been doing a whole lot of work. So I'm excited to come talk to you about the Accountable Care Collaborative Chronic Pain Disease Management Program, as well as the eConsult program. I want to introduce my colleague, Mark Corello. He's working on the Program Innovations team with us on both of these programs, and may be able to answer some of your questions better than I can. He's really been instrumental in implementing the ECHO program and now working on the eConsult program. So I'll start with the Chronic Pain Disease Management Program and give you an overview of that. It's also known as our ECHO program. I don't know if you are familiar or have heard of ECHO before. It actually started out in New Mexico. It's been going for about 10 years there. And it's a HIPAA-compliant Skype room, basically. And really what they're doing is they're connecting primary care providers throughout the state with specialists, a team of specialists that sit together. They're multidisciplinary. There's behavioral health providers, there's specialty care doctors, there's RNs, and there are specialists in a particular medical area. So what we did in Colorado is implement a chronic pain disease management program, our ECHO program. We received some legislative funding for fiscal year 14-15 and 15-16 to do the chronic pain disease management program. And actually, we were able to go to the federal government and get federal matching funds for the program. We're only the second state in the nation to do that. And so we took our state and federal funding and contracted with Connecticut. Connecticut has a federally qualified health center actually running an ECHO program, and which is the only ECHO program in the country that's working directly with federally qualified health centers. So we really like that aspect, and we went with Connecticut. There's actually several states that are doing ECHO programs throughout the country right now. We chose Connecticut because of the FQ aspect of it, and they actually contract with the Integrated Pain Clinic of Arizona to be their specialists, their team of specialists. And so those specialists meet now with our primary care doctors twice a month. We launched our program in March of this year and actually had a very strong interest from the primary care providers in Colorado. We did a lot of outreach with the Colorado Medical Society, the Academy of Family Physicians, our regional care collaborative organizations, and we're able to find 42 clinics in Colorado that wanted to participate and meet with these specialists twice a month. And what they do is they share their client cases. If they've got a chronic pain client in their office, quite often they're very complex cases, and so they're able to share the case with the team of specialists and get feedback on what they could do to treat that patient. And it's a learning atmosphere. It's a learning collaborative. So all the other doctors are listening and learning, and there's actually a chat function that happens during the clinic so that the doctors can chat to each other. And what we found in the Colorado ECHO is that the chat function has been used more than any other ECHO in the country. So our physicians are really collaborative, and they're sharing practices with each other. So it's been so fun to sit and listen and watch and learn. And so I mentioned we have 42 clinic sites. That actually amounts to 84 providers in Colorado that are participating. And another exciting thing we did with our program is we allowed behavioral health providers and pharmacists to also participate. We did require that they be part of a kind of a team, and so that they are working with their primary care doctor and co-presenting cases, so that the behavioral health provider is actually working directly with the primary care provider for this client. So it's spurring a little behavioral health integration, supporting our move in the Accountable Care Collaborative to move towards integrated primary and behavioral health care. So that's really exciting. We also have physician extenders that are participating, nurse practitioners, PAs, and that. We feel like we've done a good job covering the state. We can pass out maps that we just printed for you this morning to show you the coverage that we have. Pass around the coverage that we have across the state. So we're really excited. We did reach our cap. We used all of our funding to fill these slots. Now we're starting a waiting list. So the program lasts for 1 year, and then the physicians graduate, and we bring in a whole new crop. I want to also mention, a lot of people ask, why are you using specialists outside of Colorado? We've got our own specialists. We are actually working on developing a Colorado-grown ECHO program. The university is actually spearheading that effort, the Anschutz Medical Campus. They are working with the Colorado Health Foundation and pursuing a grant, and we want to start our own ECHO program in Colorado, and we're a partner in that effort. We'll find out later this year what kind of funding we're awarded from the Health Foundation. And then we want to identify some new types of medical specialty areas we should focus on. Things that we've talked about are neurology, orthopedics, rheumatology, lots of need for specialty care access. So we will be embarking on that effort going forward, but this here, the Chronic Pain Disease Management Program, is our first effort in ECHO, and there's a lot to learn from, and it's just a really exciting opportunity. We're right now in the process of developing the evaluation for the program. We know that's a really important component to demonstrate the return on investment for this program. So we're surveying the physicians before and after to see what they've learned, but we're also looking at utilization of the clients and the claims to see if there's been changes in prescribing of opioids or prescribing of alternative treatments other than opioids. So that'll be really interesting, and Mark's doing a lot of great work on that now, so hopefully we'll have some good evaluation data to share with you once the program is up and running for a while. So I think I'll stop there and see what questions you might have on the Chronic Pain Disease Management Program.
Yes, Ms. Blakely.
Thank you. How are the clients referred to this program?
Mr. Chairman, Ms. Blakely, it's actually a physician-enrolled program, so technically all of the clients that the physician sees would be eligible. So really it's the physician gaining more knowledge on how to treat all of the patients in their client with an emphasis on the chronic pain. Obviously, they're getting expertise. So we ask that the physicians present only Medicaid cases in these clinics, virtual clinics, but obviously the entire patient population for that clinic is really going to benefit from the physician learning new practices for treating these clients.
Other questions? Dr. Milankovich?
First of all, I want to commend the department on moving forward in this direction. I think this is probably a critical key towards getting more specialty access available to primary care providers. And I'm pleased to hear that you're thinking of expanding it beyond chronic pain. I think that's important because I think there are many other needs, at least based on the work I've been doing with some primary care providers. Access to specialty care for Medicaid clients is a challenging issue. I'm interested in the evaluation. Have you considered, instead of having the department do the evaluation, having an outside vendor do the evaluation? I mean, not that the department can't do it. It's just that I think you're always open to criticism that you're going to say it's working, right? You do your own evaluation. I evaluate. I mean, everything I do works. And so I would just throw that as something to consider, that it may be an unbiased outside evaluator might be worth considering.
Yeah, Mr. Chairman, Dr. Milankovich, I think that's a great point. Just a little bit about the evaluation. Because ECHO has been happening for 10 years in New Mexico, and it's actually in 22 states now, there's some standard evaluation metrics that are used, which has been really nice because our quality team has a lot on their plate. And so we're actually leveraging a lot of the existing metrics so that we can compare our program to other programs in other states as well. So there is some objectivity there, but I definitely hear your point on having an independent evaluator. I think that would be the preference for all of our programs.
One thing I will note on that is we have an evaluation position that's in the department. It's currently posted right now, and it's in the clinical and client office, specifically so that it's in a different office from the program folks. So there is an attempt there. It's certainly not perfect. That evaluator will be under Dr. Zerzin's office and will have some responsibilities. SIM has 3 components of evaluation in it, one of which is some internal evaluation work. And so that position will have half SIM responsibilities and half other departmental responsibilities. But we do try and attempt to keep them separate from the program staff.
I mean, the other thing you could do is you could also have a review panel associated with the evaluator to give outside people who can say, can further say,
yes,
the evaluation is good.
Yes.
The question I had is, my understanding of the ECHO program is really to allow primary care docs that really don't have a lot of access to specialists to learn and stuff. Looking at the map, they're mainly in the urban areas still. I mean, is there an effort to get this out to the rural areas where that access is even that much more limited? And what's the department's plan in that?
Mr. Chairman, we hear you on the map. There's 17 in rural areas, and actually we were pretty amazed that we were able to get that. We had to work with our regional care collaborative organizations. A lot of it is just getting some education out there on what ECHO is, and we struggle to even get providers to participate in the Accountable Care Collaborative in rural areas. But I really see things like ECHO and eConsult, which I'll talk about next, is this infrastructure that we're giving to providers in rural areas to help them along the way, to integrate behavioral health, to integrate specialty care, or get access for their clients because they don't have the same resources or the same access that urban providers do. So we absolutely see this program as a new tool, an important piece of infrastructure for those rural providers. The university effort is really focused on rural areas as well, and we've been traveling around rural areas of the state to drum up interest and see what kind of specialty areas in different areas of the state are needed. So I really see, as we continue to evolve ECHO, we will focus more and more on the rural areas and do what we can to get more of those rural providers engaged and participating.
Great. Thank you.
I think the other thing to note, while not 100% linked, I think very, very closely linked. So the current state of health that is the leading health policy agenda for the entire state under Governor Hickenlooper has one goal around reducing by 92,000 the number of folks who misuse prescription drugs. And so we think that that is a statewide challenge, not just a rural challenge. And we hope that some of this knowledge transfer that's supported by Project ECHO can move that sort of larger public health challenge along as well. Again, I'm not sure they're 100% linked, but just general knowledge and better understanding of how to manage pain so that patients get their needs met, but not manage it in ways that allow for prescription drug abuse and misuse.
Great. Thank you.
And Mr. Chairman, did you want me to talk about eConsult now?
Go ahead.
Okay, great. So this is another Accountable Care Collaborative program, another effort to improve access to specialty care in the program. I see it also as hopefully a future recruitment tool for specialists to participate in the program. It's really geared at expanding access to specialty care and reducing unnecessary specialty referrals. This program has been used in a few other states and a few other health systems. Kaiser has something very similar that they're using in their health system. In Oklahoma, we saw an eConsult program reduce unnecessary specialist visits by 30%. It's been used in California, and actually we are working with a rheumatologist who's actually out at Anschutz now, but was working in California and helped stand up the eConsult program out there and saw very good results. So he came out and he's working with us to design the eConsult program for the Accountable Care Collaborative. What we're doing is leveraging the Carrillo system. So we are running the program through the Patient Care 360 tool and working with their vendor Medicity to develop the eConsult program. We are going to start with rheumatology because we have a rheumatologist who is spearheading this, and there's a need for access to rheumatology, and it's a good specialty to do e-consults for, and he's got a team of rheumatologists that are going to work with us. And we actually have heard from Denver Health as well, and they're interested in having their specialists participate, which is very exciting. And now we just got to round up some primary care docs to participate. So basically, let me explain what e-consult is. It's an online web portal that primary care doctors can get into, fill out some information. There's a prescribed protocol of the information you have to provide about the client so that the specialist gets everything they need. You can attach lab tests, you can attach pictures, files that the specialist might need. Send it off to the specialist. The specialist generally has 48 hours to respond, but the specialist can respond at a time that's convenient for them, which they like. They can do it after hours. The staff in their clinic can help them kind of manage the response and even provide some of the responses when that's appropriate. And so then the message will go back to the primary care, and as I mentioned, what they're seeing in other programs is 30% of the time the specialist says, you can treat this client in your primary care setting. Here's what you need to do. Prescribe this medication, whatever it is. And then the patient can stay in their medical home. There's also an opportunity for co-management so that the primary care doctor and the specialist can go back and forth, and the specialist can help co-manage the client. So it's just a new technology to facilitate that curbside consult that we'd like to see happen. And so it's an exciting new program, and we are working with Korea, as I mentioned, to implement it. We're hoping to implement it in 2015, kind of giving us some space there so that we can make sure the technology is right. So right now we're in a place where our rheumatologist is getting in there on Monday, actually, to check out the system and see how it's working. And the most important thing in my mind is having something that's intuitive and easy to use. We know that physicians already have several other systems they're signing into, and how do we really make a system that the physicians will react favorably to. So we're hoping to get the system up and running this year, and then eventually we'd like to expand it to other types of specialty areas. Neurology has come up, behavioral health has come up. Again, there's really a lot of specialty areas that we could, dermatology, there's a lot of options with this. But we're really excited about this. Actually, when we first introduced Echo and eConsult, the primary care and the specialists were most excited about eConsult. And so I'm expecting to have a good crop of physicians to participate in the first round, and I'm hoping that eventually we can expand this to all types of specialists that would work with eConsult and really, again, provide that infrastructure of both in urban and rural areas that we need to support providers so that they can practice at the top of their scope and keep their clients in their medical home and only use specialty care when it's absolutely necessary. So that's the eConsult update. Is there any questions on that?
Board have any questions? Dr. Milinkovich?
Thanks. I have a question and a comment. Have you received CMS approval for reimbursement under this methodology yet, or is that still pending?
Mr. Chairman, Dr. Milinkovich, we have been working with CMS since last fall on this. Initially, we didn't actually think that we needed authority. We thought we already had authority under our telemedicine authority. Recently, they indicated that they thought we should do a state plan amendment just to be extra safe. So we are in the process of doing that. I don't expect that to take very long. It's a minor change, but thank you for bringing up payment. I should mention that there is payment for using the eConsult system. The primary care doctor gets funding, I think it's $10 each time they submit a consult, and the specialist gets $20. So, but there's an overall cost savings because you're reducing, hopefully, that specialty visit costs.
So my comment is, I'm probably telling you something you already know, but I'll say it anyhow. We've been doing a lot of work in Denver to try to create access through eConsults for specialty care because it's a big problem in the Denver community. And one of the things that I was continually reminded of by primary care providers, physicians, nurse practitioners, and PAs is if it's too hard to use,
yes,
you ain't going to do it. It's easier to say, well, instead of going in and trying to figure out how to use the software or send the referral, it's easier to just give the patient a note, go see the orthopedist or go see the rheumatologist or go see the dermatologist. So I think it's really important to think about how payment is part of it, but also ease of use. And if it just is too hard to use, people won't do it.
Mr. Chairman, Dr. Milinkovich, I appreciate your comments so much. I wish the web developers were here listening to you because I actually have delayed a little bit the project until we can get the technology right, because I completely agree with you. If it's too challenging to use, we're not going to succeed. It's not going to be a good program. So I really appreciate your comments, and I hear you.
And following up on that, anytime you can do a single sign-on, it's going to make it that much easier. And like you said, if people have to sign on to 4 different systems, it won't happen.
Yep.
Yeah. Great, thanks.
Thank you so much.
Other questions? Great, thank you very much for the update. It's exciting stuff, and we look forward to hearing from you in the future of how it's continuing.
Great, thank you.
Thanks.
Thank you.
All right, now we're going to go to the Customer Contact Center overview. We've got Christine Comer here. This is on our it's a PowerPoint presentation that will be on our iPad. We only have one screen up here, so I'm going to have them point that to the audience. And so if we could all watch it on our iPad would be helpful. So that means I need to be able to get to that in my iPad, which is always a chore.
Just keep it back.
Yeah, that's what I keep doing. I screw it up every time. Okay. Call center for that.
Great.
So welcome. Sorry we're moving so fast for you today.
I was a little surprised, to be honest with you. Let me run over there with my umbrella, of course. So good morning. Thank you for having me today. My name is Christine Comer. I am the Client Services Division Director. And for those of you who are unfamiliar with who we are, the Customer Contact Center is the department's main centralized customer contact and assistance center for inquiries and problem resolution for all medical assistance programs managed by the department. The Customer Contact Center provides assistance through its call center, email inbox, peak chat, and we guide members in accessing health care, understanding their services and benefits, navigating the health care delivery system, and providing general information to the public. So we always like to start our presentations by talking about our mission. So our mission with healthcare policy and financing is improving healthcare access and outcomes for the people we serve while demonstrating sound stewardship of financial resources. And today I'll be focusing on that people we serve, the outcomes for people we serve. Today we'll be going over an overview of our current operations, kind of our call volumes and staffing challenges, opening our avenues for contact. We'll be talking about how we're leveraging technology through our customer relationship management system and our interactive voice response system. Again, the peak chat and our online forums. And then I want to talk to you a little bit about our vision for the future, which includes a budget request for staff. So I've been working with my team internally. As you can imagine, a customer contact center can be quite overwhelming sometimes for agents. They're on the phone all day, and I've been working with them in trying to find a purpose statement that really anchors who we are and why we're here. And it really has reinvigorated and re-energized the staff when they look up and they see our purpose statement on the wall. So I'd like to go over that with you. So the purpose of the Medicaid Customer Contact Center is to effectively assist you by providing clear, concise, and accurate information every time. We do this by serving as a resource and the public-facing point of contact for the department. We are the voice of the customer, both internal and external, and we assist with the navigation of complex health systems by providing direction and guidance to expertly address your inquiry with compassion and understanding. So we're a very small center in terms of staffing size. However, we have a large client base, as you are aware, with more than 1.2 million people currently receiving Medicaid. There are many avenues and doors that clients have to get assistance with Medicaid that includes county offices and MA sites, and our center is just one small piece of that puzzle. The information here provides you with a quick snapshot of the volume of calls we received in the month of April 2015. So in April, more than 60,000 people called our customer contact center, and of those, we answered a little more than 13,000 calls. The average wait time was around 9 minutes, with the average talk time of almost 8.5 minutes. So since I started my work with HICPUF almost 3 years ago, we spent a lot of time developing our IVR and making the call tree simple and easy to navigate. So when you see here that 60,000 people called, but only 21,000 went to an agent, there are many reasons why. We share a lot of upfront information in order to divert calls and make certain people get where they need to be quickly. For example, during open enrollment, we let people know that they need to shop for insurance, that they should be calling, another entity, Connect for Health, for that process. And then with each queue option they select, we have FAQs, frequently asked questions, that people can go through to see if that answers the question. And we have many self-service options such as ordering a Medicaid card, requesting a provider notice letter, and we also let callers know that they can find their answers on our website or report changes on Peak. All of this contributes to the large discrepancy between who reached our number and who actually opted to speak with an agent. So in addition to reaching us by phone and email, in June of last year, we opened a chat function within the PEAK application that allows consumers to reach us electronically by chat. So at this time, chat is available between the hours of 12:30 and 4, and when it isn't available, consumers can send us a request via email that we respond to as well. So last month, within this chart, you also see we conducted almost 500 live chats, and we responded to more than 2,000 online requests. So that's in addition to our call volumes. This is just a graph that illustrates the type of calls that we received in April. So a quick glance of this demonstrates that most of the calls we received were eligibility related, followed by questions about the Affordable Care Act and explanation of benefits. So in the Medicaid Customer Contact Center, it was originally designed to assist callers with their billing and benefit questions, but in our world, eligibility and benefits are often interrelated. So it makes sense that we take calls that have a component of eligibility to them. Additionally, we have learned since the implementation of the Affordable Care Act that we are taking far more calls related to eligibility than ever before. And one reason for that is that we're educating an entirely new population about Medicaid. Another is that our county partners and MA sites are also at capacity in terms of being able to take calls and respond to inquiries. So additionally, in the last year, we've learned that the average length of call that we take has increased over time. Our average call length prior to the Affordable Care Act was around 3 minutes and 50 seconds. It's now more than 7.5 minutes. So again, we find that we're taking more time to explain to our members about their eligibility and educate them about their benefits, how to retain Medicaid when they have it, etc. So just in April alone, there were more than 2,600 calls related to eligibility, 1,400 for the Affordable Care Act, and I think we had more than 1,000 benefit-related questions. So
could
before,
could
go
I
ahead.
do back up and
Absolutely.
one definition on the abandonment rate?
Mhm.
What is that?
So the abandonment rate means that once an individual has gone through our queue and they've decided they want to talk with an agent and they're put into hold before the agent becomes available, they may opt to abandon. They may say, I'm done waiting and I'm just going to hang up. And there's several things that we're doing to address that. So again, self-service options has really diverted a lot of those types. You know, if somebody can help themselves, we want them to help themselves, and then when they really want to talk to an agent, we want to make sure that we have the agents available. We'll get to some of that with our budget request, but that's what the abandonment rate means.
Does your system identify what the average wait time is?
Yes, it does.
As you're listening, it'll say your average wait time is...
So we have a system right now that
we've all been on hold that
Yes.
you don't have any idea if you've been forgotten.
Exactly. So while they are waiting, we do come in with additional messaging, and the system that we've procured and we've been using right now has had some limitations in terms of delivering an accurate average wait time. You know, you can expect your call to be answered in the next 12 minutes. We've had some problems with the system that we're using right now, so we are looking for some solutions, which may include re-procuring a different system.
Okay. Dr. Michaelovich.
Thank you. I applaud you for having these metrics available. I'm sure you're not happy with them.
No.
Do you have targets for what you would like to see the average wait time be and what the abandonment rate would be?
Yes. Our goal within the center is to answer, our service level is kind of to answer 80% of the calls within the first 5 minutes. So with that metric, what you would see is an abandonment rate far less than we'll get within the 10% area, and then we'll be able to, answer more, 80% of the calls within at least 5 minutes. The average time industry-wide of an individual who wants to wait on hold is about 5.5 minutes. So our goal is really to get to them before then.
The other thing I think we're all adjusting to, Dr. Milankovich, is I think our county partners and MA sites, certainly Connect for Health Colorado, now that we have described open enrollment periods, Brenda can speak to this, some of those service level agreements we have to think through a little more nuanced than in the past when we had, and Medicaid eligibility is throughout the year, but there's a certain period of time when we're driving toward enrollment at the exchange and things. And so there's some adjustment there that I think we're all trying to sort through as we've been through this now twice. And we'll go through it again a third time as we come up to November of this year. So there's some adjustment. I think everyone is learning, at least from my time on the exchange board, and I know Brenda can speak to that, of how we can anticipate the changes in volume given the enrollment deadlines that are created by the Affordable Care Act.
You also may need to measure the metrics in not just on an annual basis, but on a
Exactly. So there may be there's standards, and then there's differential given the time, given the volume. The volumes on the final days of open enrollment are just astronomical.
Yeah, they're just interesting, very interesting. we have learned from the last 2 years of kind of culling and reviewing the data that our downtime, even though Medicaid is open year-round, we do see a dip in the call volumes May through September, and then they start to peak again coming in October and November.
Great. Thank you.
So a couple of system definitions for you. These are a couple I've already used, and you're going to hear frequently throughout the rest of the presentation. The first is the Customer Relationship Management System, or CRM, and that's a system that is a record of the interaction between the phone agent and the caller. The second is the Interactive Voice Response System, or IVR, and this is our telephony system, or essentially the call tree. These two systems are interrelated and are used together to improve our customer experience. Because our call volumes and the size of our center, it's critical for us that we're as efficient as possible on our phones. So with the implementation of our new CRM and IVR, it's meant that we've been able to automate, as I've stated, some processes and calls that previously needed to be handled by an agent. So, for example, a customer calling in and requesting a Medicaid ID. We've automated that function, and we used to handle more than 3,500 phone calls a month simply for a Medicaid card. Now that an individual can order it automatically on the phone, bypassing an agent. So when we procured the CRM and the IVR, we purposely sought solutions that could integrate with the other systems that the agents use. So when we rolled out, we were able to establish a connection with our eligibility system, or CBMS, so that real-time eligibility data and the results are delivered to the agent desktop. And additionally, in June of last year, as I've mentioned, in collaboration with CBMS Peak team, we built the chat function, and that goes to our call agents as well. So citizens have the option of submitting a request directly to our agents when the chat function is closed. We've also been able to automate other functions besides the Medicaid ID, such as requesting a provider notice letter. And all data between the IVR and the CRM is recorded and trended to look for more opportunities to maximize efficiencies. So this is just an overview of kind of the benefits of what we've implemented. Everything that we've implemented is to enhance the customer experience. With the IVR and CRM working together, our agents have several tools at their fingertips that make the call handling more efficient, thereby improving the customer experience. For example, ticket management within the CRM. Every interaction between a caller and an agent produces a record of contact that indicates the reason for the call and how we handled it. Was it resolved? Did we have to refer them out to another entity? And if so, what were the results of that? Knowledge articles. Consider this kind of a Google database for call agents. It's a database of information that is delivered to the agent desktop as they're actively working through a call, and the information helps them guide through the call, providing them with information on the right questions to ask a consumer and the best information to give the consumer so that they're effectively responding to inquiries. And our Peak online portal. So our call agents manage the online functions of Peak, as I've mentioned, and we have an option for clients to send us a ticket when it isn't open. And then coming in June, those knowledge articles that our agents use will also be available for public consumption. We have some really great reporting features, so we can create reports ad hoc and on demand. Reports can be run both in the CRM, which helps us identify top call reasons, trended, if a letter went out, are we getting a spike in calls related to a letter or a notification, first call resolution, and we can also pull data through our IVR. Are people using the FAQs? If they're abandoning or dropping out, when are they doing, how long are they waiting, etc. So this, as I've said before, both systems work together to provide a more efficient agent experience. When an individual calls in, they are prompted for identifying information and the reason for their call. The system then pings our CRM to see if they're known to us, if they called us before, and if not, it then pings CBMS to identify the individual within that system. If they are known to us or if they're known to CBMS, the agent's going to receive a screen pop on their desktop telling them why the person is calling, the number they're calling from, and their CBMS identifying information, such as their name, their date of birth, their eligibility information, such as the category of aid, the med spans, their address, etc. All of this information is populated into the CRM so the agent doesn't have to enter it manually. And again, it just makes them more efficient. And as this slide demonstrates, what happens right now is a citizen can opt to interface with us by phone or by peak. The system goes through, comes into our call center, it pings CBMS, and then the data is delivered straight to the agent desktop. It's real-time eligibility data, so even though our agents could go into CBMS and find this, what is really beneficial about it is that they, everything that they would need to search is delivered in one succinct, very concise file right to their desktop instead of having to go into 12 or 15 different slides or fields within CBMS. And this is the call center desktop. So this is a view into the supervisor desktop. This is a tool to monitor the real-time performance of the center so that we can react to call demand and staffing ratios. In the upper left side of this graphic where it says queues, what this tells us is how many people are currently waiting in queue to speak with an agent. In this instance, we have 12 people waiting to speak with someone in our main call queue. And I should mention that we currently have 3 separate queues. We have one for phone applications and the back office processing. We have another for Arapahoe County. They're testing our system and they're partnering with us right now. And then we have another one for our main call queue. And it's soon to expand to 4 queues as we bring in Denver Health. Adams County will also be joining us as well. We can view the performance of the center in the last 24 hours or in the last hour. And as what we see here, in the last hour, we answered 92% of the calls that we received. Current maximum wait time for any single caller is 5 minutes and 41 seconds, and the average wait time is 3 minutes and 4 seconds. On the right side of the graphic is a snippet of the individual call queues. So for our main call queue, we isolate call types by selection through the IVR. And here we see that we have one person waiting to talk to an agent about benefits. We have 12 waiting, or 4 waiting to speak with somebody about eligibility, and we don't have anyone waiting to speak with a Spanish-speaking agent. So we also can see what the average wait time is in each one of those individual queues. How many agents we have skilled or assigned in that queue, and how many are actively taking calls, and how many are not ready. Maybe they're on break, or they're doing wrap-up, or finishing a call. And as I stated, this tool assists the managers in assisting call demand or assessing call demand so that we can easily move agents from one call to another as demand changes. So, for example, if we had 12 calls waiting for eligibility and only one agent assigned, but 4 agents assigned to a bilingual queue with no one waiting, we can move agents over electronically to take eligibility calls and keep the queues rolling along. So, in the past 3 years, we've worked through several iterations of making improvements within our call center. We like to focus in the kind of an industry standard for call centers is focusing on people, processes, and technology. So our first step was focusing on our people, establishing clear performance expectation for the staff, including reclassification of the positions so skills matched responsibilities, establishing clear performance goals that aligned with the department's strategic initiatives. We then focused on processes, so we completed a pretty intensive lean process evaluation for the center in 2012. It allowed us to identify gaps and overlaps and inefficient processes. So we revised everything from our call handling model, call scripting. We reviewed everything for inefficiencies so we could maximize the customer experience. The last thing we did is we focused on technology. So we implemented the CRM and the IVR systems in 2003, which aligned with the rollout of the Affordable Care Act. And what we realized at that time is we had unprecedented call volumes that we were unable to measure before because we had an antiquated system that couldn't tell us how many people actually called and got a busy signal and couldn't speak to an agent. So whereas we thought we had a fair measurement of the volume of calls, it was really 3 to 4 times what we were aware of. So after going through all of that, and we're still performing kind of at a 30% abandonment rate or more, we felt that the only solution now was to add staff. We feel like it's a sheer mathematical problem that we're trying to solve, and the call demand, as we realized, as our increasing client base. So we submitted a budget proposal, which was approved, and it will convert 5 grant-funded positions that are currently housed within our call center, and it's adding 12 call agents to our center. We do believe with the additional staff that we're going to be able to meet that goal of 80% of our calls answered within 5 minutes. We've also received some additional enhanced funding, which will allow us to implement even more solutions within our automated systems, such as client callbacks. So, for example, an individual who's waiting on hold, they'll be given an opportunity. Would you like us to save your place in line, and we'll call you back when your place comes up? Or would you like us to call you back at a designated time that's convenient for you? This is something we'd love to implement, but we haven't had the funding nor the staffing to be able to do that. And we'll have more options within our self-service portal that are already, we're already releasing mobile applications that allow consumers to print their IDs or update their address from their mobile phone. So our goal through all of these efforts is simply to increase customer satisfaction. We want to provide options to those consumers who want to help themselves through self-service, and for those who want or need to speak with a representative, the people who really need the additional care. So additionally, we've also started making minor eligibility changes and updates within CBMS. If a client needs to update an address or a date of birth, or they want to report the birth of a baby, previously we needed to refer that caller back to their county of residence to make the eligibility change. And now we're handling those very small minor changes within our center, and I can tell you that the client response has been overwhelmingly positive, and our eligibility sites have also reacted very positively to that. Our primary goal within the center is first call resolution. So within our improved systems, we're able to connect stakeholders such as eligibility sites or RICOs or SAPs, anyone who may play a part in solving any particular client issue or concern are the people we want to connect with. So we're changing the landscape of the consumer experience. Instead of a center that focuses on the number of calls that you've taken, let's focus on the quality of the call. Are we able to prevent an individual from ever having to call us back? We're also thinking about potential downstream challenges for that individual and solving that problem for them the first time they call. So, for example, brand new member calls us needing assistance. Finding a provider, we connect them with a provider list, help them select one. Maybe they need an appointment. We connect with the provider and help them schedule an appointment. Or, hey, we noticed that you have a 6-month-old child. Are you up to date on your immunizations? Can we connect you with a provider who can provide that? Or can we get you connected with health communities? So while we have them on the phone, we want to solve as many problems as we can and that we're capable of doing. So, with that said, I like to close by sharing a message that I share with my team every time that we meet, which is Friday mornings, and this is what I like to tell them, is that every call that we handle and every person and family that we help, it's our opportunity to change the perception of government. It's our chance to let consumers know that we care about their individual situation, that we're knowledgeable, efficient, and we are here to help. So, with that said, any questions?
Questions? Yes, Ms. Blakely.
Clarify for me, the budget says 25 FTE.
Mm-hmm.
So, and the numbers you gave
So,
Student math.
yes, so of the 20, 5 of them are existing positions that have been grant funded that are simply going to roll over to permanent positions, and then 20 additional call agents. And I can tell you something else that we've proposed is that I'd like to take of those 20 positions, 6 of them, and create 12 part-time positions that can literally fill in the gaps during our very high volume areas, the lunch period. So between 12 and 2, where we have to release staff to go and take lunch and breaks, we are then backfilling with temporary agents who are going to be able to work strictly from home 4 hours a day. So again, we think that we're going to be able to really effectively meet demand through those solutions.
Other questions? All right. Thank you very much for the overview.
You're welcome. Yes. I would just love to throw this out here. If anytime you want to come in and see what we're doing and what's going on, feel free. We have some very exciting things that we're doing in the call center. We'd love to show you. So
I'm sure our retired doctor would love to come.
Yeah. Thank you so much.
Thank you.
In the call centers, I never want to go back.
If I can just say something as well. We've been able to also connect Christine with our call center at Connect for Health Colorado, and really having that management team work together as we're trying to figure out what is the correct process for people calling all over the place. So we're meeting, I think, every other week, to really address a lot of the issues and really compare the different calls that we're getting. They're getting Connect for Health Colorado customers, we're getting Medicaid customers, and really seeing how we can get the individuals to call the right place and get them the help they need immediately. So.
And we're also sharing scripting and messaging so that we're very consistent with our mutual consumers. So
we're getting prepared for open enrollment
already
in May.
Good. Thank you very
Thanks
much.
Thanks again. Have a great day.
Thank you. Terrific. So,
Gretchen, it's all you.
Yes, and we've plowed through the agenda today, and I realize we haven't had a break, so I will be brief, but also want to provide the update. The first is congratulations to Mandy and Pat. They have made their way through the confirmation process, so they are continue to be here. They were favorably recommended for confirmation by the Senate Health and Human Services Committee in late April and approved by the full Senate unanimously on April 29th. So. That is the one update, but we'll continue to get more for you, Christy. I did want to mention an update around the Accountable Care Collaborative. Josh mentioned it. It is our largest mechanism of delivery system right now. It's a managed fee-for-service structure. You all are well familiar with it. We are coming up to ACC 2.0, which is our chance to re-procure the current structure. Right now, there are approximately 835,000 of our 1.2 Medicaid enrollees who are served through the Accountable Care Collaborative. So for those of you who have been tracking this program for a long time, I'm not sure any of us imagined it would be quite that large across the Medicaid volume. I'm not sure we anticipated we'd have 1.2 million Coloradans served by Medicaid at this point either. But the new ACC model does start on July 1st of 2017, and in my 5 months of being here, I've learned that government time has this amazing contracting and expanding capability. Things take longer than you expect, and then things that seem really far away have to get started very early. And so we are in the process right now of putting together our concept paper for what the second version of the Accountable Care Collaborative structure is going to look like. The great thing is many states have taken on to this activity. There are all kinds of different constructs that we have the ability to study. The latest from New York are these entities called Provider Performance Systems. Oregon has CCCs. Washington has something else. There's something else yet, again, in Minnesota. So while Colorado was a little bit on the leading edge of trying to figure out how do we bring more accountability to care for folks, now we have lots of partners in this work. So it's very exciting. We did release, and this is part of the most important part of the update, we released a policy paper, a brief one, to try and help some of the people who are interested in helping to participate in the procurement process to know some of the early policy decisions. And so we will be contracting with just one administrative entity. Right now we have, as you may know, BHOs and RICOs at the local level or at the regional level. As we look forward to July 1st of 2017, The department anticipates contracting with just one administrative entity where in each region who will be responsible for the duties that have traditionally been performed by the current RICOs and the current BHOs. So the state will use the current RICO map. As you look across the map, the BHOs and the RICOs line up fairly well with the exceptions of Elbert and Larimer County. And so we have committed and have already started to doing a deep dive into the data of the experiences of patients and providers in those two counties, doing community outreach and engagement in those two communities, and trying to begin a conversation about which part of the regional alignment works best for those communities. So that work is our commitment and will be part of this summer. We do anticipate that over the course of the next RICO process, so from July 1st of 2017 on, that we will have changes to aligning payment structures across those entities that will incent value and quality of care. But we recognize that as we begin these contracts, most physical health services will continue to be reimbursed via a managed fee-for-service mechanism as they are today. And that the payments will continue to, for behavioral health, will continue to initially be capitated. So we recognize there's opportunities for better payment alignment, but we need to create the appropriate glide path for those. Some of the other states have allowed, and I'm not suggesting that we're going to do this, but we're seeing other states do this, sort of allow for two paths, bidders on the contracts to pick one or two paths, to look at how their payment might evolve over the course of the contract. So we're looking at all of that with, again, the end goal of creating payment mechanisms that incent value and incent quality of care. So that announcement has been made. We've gotten feedback from stakeholders that have at first and most importantly said thank you for the clarity. We knew that there was a lot of time being spent trying to guess where the department was going, and so that's why we made this decision. It is certainly not all that will be worked on over the next year and a half, but we thought an important first step. So I'll stop there because that's sort of important stuff. Does anybody have any questions?
Do you have some sort of white paper or something that could be shared about what your overlying philosophy and plan is with consolidating them to one administrative entity?
So we are working on something like that. We're calling it a concept paper at this point. One of the things that is required, as you all well know, is that we need some federal approval on a variety of these things. And so we're feeling the need to put some structured words to paper to start engaging our federal partners in that. The RFI from last fall, you may recall, we had 70 questions and 4,000 people responded, or some crazy amount of volume of information. So some of these concepts were outlined in the preamble to the RFI, but I think we're getting further and further along, and so we'll be releasing that. The noticing requirements of some of the federal waivers will require that we have that all out and for public availability.
So Larimer is going to move to the RICO region for mental health and substance abuse?
Unsure. I think that I think what we want to do is figure out which is the best for those patients and providers. So I don't think there's a decision made yet of those two. We held out Larimer and Elbert to say those are places where ongoing conversation needs to be held to figure out which regional alignment works best for them.
You don't think it makes sense that you're part of Western Colorado?
So the next
Question.
is, yeah, go ahead. I'm sorry, Paul.
Thanks. I understand that it's going to be the RICO are responsible for both physical health and behavioral health.
Oh, let me clarify. There will be a contract to one administrative entity. So I think that we are not describing how the relationship for that entity will be. So there's lots of opportunities for people to build partnerships to be that contractor, but there will be one contract per region.
That's what I wanted to clarify. It's only one per region. There won't be multiple contractors within a region.
Correct.
Thanks.
Okay, so I know an issue that came to the board in February of 2015 related to the revision to the Colorado Choice Transitions. As you may recall, it was focused mostly on removing two of the demonstration services. because they weren't being used or they were being covered by other services now through the Medicaid state plan. And then there was quite a discussion, a robust conversation around the guardianship language and how that was going to be appropriately worded to meet legal requirements as well as the needs of stakeholders. And so the department has been working to address these. We didn't want you to think that it sort of like the call center, still waiting. We didn't want you to think that nothing had been done. There has been an ongoing and active conversation, working with stakeholders, working with RAGs. The group has included the Disability Law Colorado, the Attorney General's Office, advocates, family members, and guardians. Follow-ups have been scheduled with identified stakeholders for this week and next, the week of May 18th. And the revised rule is on track to come back to you all at the June MSB. So we just didn't want you to think that we had forgotten it and that we have done what we committed to do, which was to try and engage all the stakeholders to find the common path. Again, I think as Jen said at that first meeting, we had some agreement about what we were trying to accomplish. We all just needed the language to be comfortable so that we were clear about that. So that's where that will come back in June. All right, the CDOS open enrollment, the board adopted a rule in November of 2014 on the financial management services structure, and I know sometimes, again, it feels like you promulgate rules and then not sure what happens to them. The open enrollment period began January 1 and will end on June 30th for that change of the financial management services structure. The department has contracted with a separate training vendor, Consumer Direct Colorado. The training vendor trains both the clients and the case managers on the CDOS program. The vendor is responsible for conducting 2 face-to-face case managers trainings per quarter. And they also provide training to CDOS clients either in person, over the phone, or through a self-paced online training. During the first quarter of the consumer-directed training, there have been 176 clients and 155 case managers trained. So again, continuing to build sort of important knowledge around this work. Clear transitions to 3 FMS vendors and there have been clean transitions to 3 FMS vendors and 2 employer models. So there have been no gaps in services, positive feedback from clients on the fiscal employer agent model, and there has been ongoing feedback in favor of providing clients with the choice between the FMS and employer model. So beginning in the state fiscal year of 2016, the department will offer quarterly open enrollment periods for the CDOS clients. So implementing that as you all had helped us to do. I won't give you much on the targeted rate increase because Josh provided that in the overview and you were given it. I think it is there's just 2 things that are probably important to note. The timing of the legislative process, the July 1 start date, and the engagement with the federal government to approve those rate increases don't really line up. And so it has been our attempt to try and use the opportunities of additional budget opportunities to do some targeted rate increases so that it's not just across the board, everybody gets a tiny amount, but that we're able to use that strategically to support things. That does, though, make for additional administrative work. So for the 12 targeted rate increases, we've already got this wonderful spreadsheet going. The finance offices and the program offices are working hard to get them moving. In fact, I just cleared the first 2 this morning. They will always be retroactive to July 1st of 2015, but we know that that's not helpful for providers who are anticipating those rate increases. And so we're working as hard, and you'll begin to see those rules coming before you. But I did just want to let you know that it can be a little confusing for providers who read the statute and say, the Joint Budget Committee expected that this would be done on July 1st. And we have to say yes, but since the federal government pays for part of these services, we sort of need their approval. And so we have to wait for that. But you'll be paid retroactively to July 1st. So just wanted to give you the heads up of that. It's in the end of Josh's legislative update, but this will be potentially the last year that we have a targeted rate increase that is like this. Senate Bill 228 is transforming this targeted rate increase process to what we're calling more a systematic rate review. So we can go into all of these details, but essentially what will begin to happen is over the course of a 5-year period, most of the rates that are paid by Medicaid will have a chance to have a thorough review. It's probably not going to break out 20% every year because some things are huge and some things are small, and so it will move over time. But the goal would be that it's no longer this only when providers call us and say we've got a problem with our rates, or when a benefit manager through the course of their natural operations recognizes that we're a little amiss in our rates, but that we now have a rate review process that allows for everyone to, in a transparent way, look at the rates that are paid for most services. The legislature added a 24-member stakeholder advisory committee to help guide the department's work in that area. That stakeholder is outlined in legislation. Each person who will be on the committee, those will be appointed by legislative leadership. They are to be appointed in August, I believe it is, with their first meeting to be by the end of this year in September. So we're working to get that group up and running, but it will create a more systemic way that we'll be looking at our rates. It does not, however, presuppose, this is really important, either a rate increase or a decrease. It is simply a review, so that if there are chances for us to increase things, we will have that chance. And in the times of budget downturn, we'll know where we might have the chance to change rates in the other direction and not potentially impact services. And so it's going to be a shift for all of us. It's a shift for our benefit managers. It's going to be a shift for our stakeholder community. It's going to be a shift for the legislature. But it's an important thing, and we're going to work hard to make it successful. Last thing, county director trainings. There are some trainings that are coming up. County directors will receive a $300 stipend to participate, and it's in partnership with the Colorado Human Services Directors Association and the Colorado Department of Human Services. I think you've seen from this administration, we're trying to be as collaborative as possible and not getting multiple trainings going. We have lots of issues on track, allocations, the relationship between the three major state health agencies, data, county department initiatives, grant and pilot programs, differences between Medicaid and Child Health Plan Plus, those kinds of things. And so those trainings, we just want to know you all to know that they're coming up. They will be on May 20th and 21st down here at CDHS. So that's it.
Very good. Any questions?
Oh, one last thing.
It's great to have that training, I have to say.
Good, good. I don't know if you all saw, Elizabeth's comments reminded me, the state of Colorado was just successful in securing 3 new federally qualified health center new access point grants, which is a big deal. So there are 2 of the systems were already operating as lookalikes. Access Health System down in Cortez, which is an integrated behavioral health, my understanding is integrated behavioral health system. They are now a new access point, so a full FQHC. Summit Community Care Clinic, which also was operating as an FQHC, is also now a full federally qualified health center. And the Marillac Clinic in Grand Junction has become designated a new access point. So that brings the total number to 19 in the state of Colorado. So an incredible, robust safety net structure through our FQs, and then in addition to those remaining community-funded safety net clinics.
Great. Thank you. Anything else from the board? Otherwise, we get to venture back out into the rain and see what's happening out there.
Actually, it's hard with those things to know.
Well, thank you all very much. We'll adjourn this meeting, and look forward to seeing you all next month.
You need to go to the
I did.